And so years ago, I was asked by a wellness center to come give a talk about first children and how parents adapt to their first children. So there was a large crowd of parents. And I said, what do you want to get out of this talk? And they said, we're all about to have our second child. How do you deal with that? So, okay, so I never asked that anymore because I was prepared for the former. And since you're wearing masks, now that's much better. Since you're wearing masks, and one of the things, I've been giving a lot of lectures virtually, and virtually there's very little feedback. I was thinking, but you still have masks on, so part of the feedback I rely on from the audience is not there. So if you're really disgusted with what I'm saying, I need to see really obvious manifestations of disgust and vice versa. And also, I noticed there are a lot of really good presentations on, so make sure you're in the right one in case you want to go to one of the others. If you are here mainly for a really in-depth talk about psychopharmacology, you're going to be very disappointed. That's not my field. And I will talk a little bit about that and how to talk with your physician about your concerns about medicines and so forth. But I'm a psychologist, not a physician. So I think those are all the disclaimers, other than to say I have no other relationships to disclose with any agencies. So, and I also have not timed this talk. I have gone over it several times. I had a 6-hour drive from Jackson the other day, and so I went over it several times without veering off. I wasn't reading the PowerPoint, by the way. I was just going over it in my head. So I don't know about the timing of this. So you're free to ask. I don't know if we're going to hold questions to the end. I know the chat questions will hold to the end, but if you've got questions that are pertinent to what I'm discussing at the time, certainly fine with me for you to ask. So I want to cover a little bit about the neurobiology, but just a little bit about the neurobiology of this condition and why that might predispose someone to aggression. I want to talk about some of the neuropsychiatric components with an emphasis on aggression. And the bulk of what we'll discuss, hopefully, is what's known and not known about management of aggression from a pharmacologic standpoint, from a non-pharmacologic standpoint. So with reference to the physiological factors, there are some things that are taking place in the brain during a degenerative process, primarily in the frontal regions and the caudate and the amygdala. So these are parts of the brain. Do we have any neurobiologists here who are going to tell me I'm completely wrong about this? These are parts of the brain that are very important for assigning emotional valence to what you see and what you perceive. So when your amygdala is lighting up for things that it shouldn't be lighting up for, you're getting angry about things that you should not be getting angry about, that's going to be a problem. When frontal lobes that are doing a lot of upregulation and downregulation and modulating your emotional response are being affected by this condition. So those two things prime you for misperceiving and misacting, if you will, in certain situations. And also the other hypometabolism takes place in the frontal region, loss of certain receptors and so forth. That's not the way to do it. This may work better. All right, so there are also some basic neuropsychiatric symptoms that contribute to decreased quality of life for the individual, but also place an increased burden on any caregivers, whether it's a single caregiver or multiple caregivers, professionals, non-professionals, or a combination. And there are some fairly common symptoms for those neuropsychiatric symptoms being irritability, obsessive compulsive symptoms, and delusions. And I believe we have our first quiz of the morning. So this will require audience participation. So what is your guess or your knowledgeable answer about the prevalence of neuropsychiatric symptoms in this condition? How likely is it for someone with HD to manifest a neuropsychiatric symptom during the course of the condition? 100%. You guys have looked ahead at the slide. Okay, so I should have thought about harder questions. So at some point during the course of this disease process, everyone is going to have some incidence of some neuropsychiatric symptom. Hopefully not all, and hopefully not for continuous and intense periods of time. And there are generally, did I miss? No, I didn't. All right, so, and these have been aggregated into 4 basic categories just for convention's sake to think about prevalence of the condition. Depressive symptoms like depression, morbid thoughts, suicidal ideation, anxiety, apathy, which includes self-efficacy or decreased negative self-efficacy, obsessions and compulsions, perseveration. I'm going to assume you don't need examples of those things or further discussion. Self-efficacy to me is a really big deal. I think it is one of those conditions. Albert Bandura was a psychologist who, when I was in graduate school, was one of the first big proponents for that. So this has been a really long time ago. But the idea is that this is not just self-confidence or increased morale, but it's your belief in your ability to deal with a particular situation. So as you might imagine, if you're in any situation where your self-efficacious thought about yourself, that sounds too wordy, is that I got this, and you truly do probably have this. I have a 7-year-old grandson who plays soccer, and he often says, I got this, and he doesn't, but he's 7 years old. So, but if you truly do have it, then that helps you through very difficult situations. So irritability is the third of the aggregate, and then psychosis, hallucinations, delusions, and so forth. But this is a multifactorial thing. So aggression is not simply brains going this way or brains going that way. It is the disease process itself. And so for that individual, what does their disease process look like? How far along are they, and so forth? But there are multiple situational factors as well, socioeconomic status being one of those. As a really trite example, when I was driving over here Thursday, my wife texted me a picture of the coil for our central air conditioner. I didn't know there was a coil to my central air conditioner. I have one. It's frozen. And this morning they are putting in a new central air conditioning unit. If you've priced those recently, you know those are not cheap. And so if we had not thought last year, sooner or later we're going to have to get a new central air unit and started saving for that prospect, that, again, trite, but if we have the money aside and the catastrophe happens, it's like, well, let's put one in. And if we don't have the money, it's what are we going to do? So if you're in a situation where you have fewer and fewer resources and you're dealing with someone, you're the person with HD or you're the caregiver or provider, and you're trying to come up with resources, and your resources to pay for those resources outside of insurance and so forth are dwindling, that makes this situation more stressful, leading to or contributing to the overall condition. Also geographical. Some people are lucky to live near really good clinicians and other resources for service. Some people are not. So the further away you are from those services, the more challenging that is. And also just the simple idea of caregiver availability and accessibility, not just family caregivers, but extended caregivers for respite for the family caregivers and so forth. So this is, as you see, there are a lot of moving variables here. And also psychological factors. So the individual's incoming or pre-morbid, pre-existing behavioral health history is very important. If you are an individual who has always been generally positive and without significant elements of anxiety or depression, and then you have this condition, you're going to adapt to it differently, likely, than somebody with a long history of severe depression or personality disorders and or more of the same. All right, so aggression, which is what we're here to talk about, is one of the primary factors that leads to hospitalization for this population. It's associated with higher rates of nursing home placement, and it certainly does place family members, caregivers, and others at risk for assault, because that is one component of that. Now, what I was struck with in looking at the literature is aggression is one of those things where it means different things to different people. And so that's okay when you're having a casual conversation with friends, but when you're doing research about something, you really need to be careful about how you define something. So this is just one suggested operational definition, if you will, just an overt act that inflicts uninvited force, harm, damage to a person or an inanimate object, so it doesn't just have to be against a person, or a verbal behavior that's delivered in an intimidating manner. That seems to cover most of the critical elements of aggression. Now, a little bit about this. There are some neurologic conditions that have a very, very large population, And they have agencies like NIDRR, National Institute of Disability and Research, and I'm not saying it correctly, it's some Rehabilitation Independent Living is in there somewhere. They have funded model systems programs for brain injury for 20 years or more, and where there were 12 or 13 sites across the country where they have followed tens of thousands of patients with mild and moderate and severe head injury. So there is a database that is continuing to be accrued about diagnostic issues, about treatment issues, whether it's pharmacological intervention or rehabilitation or behavioral intervention for aggression. So there's this ever-expanding database. So if you're a clinician dealing with a head injury, if you have access to that database, you can look at that and see exactly what the current thought is about that over thousands of studies, tens of thousands of studies. Why is that important? If you have a data set that has one or two people in it, how confident are you in extrapolating from that data set to the next person you see in your clinic? You shouldn't be very confident in that, because the smaller your data set, the less likely it is to really transfer to that knowledge. It's a working thought, might work, might not. It's better than not knowing anything, but the larger your data set, the more confident you are. So even so, in some cases, like with head injury, for certain conditions, there are now, and plenty of other neurologic conditions, there are literally standards of care. This is the accepted practice for treating this now, so much so that if you as a clinician go outside of that, you need to really be careful to document why you've deviated from the standard of care, because you could be liable for bad outcomes. In this case, there's still a lot to be learned about this population. So clinicians like me, and then physician clinicians as well, and nurse practitioners and physician assistants look at when they see somebody coming into the clinic for a condition they have not seen or only seen a few, they'll look at the literature. Literature is either there's case studies, we saw this one person, this is what we did, or it's peer-reviewed things that look at a series of patients coming into a clinic for a certain condition, or ideally large studies where they take a large population with a certain condition, they randomly assign them to one or more treatment conditions, and from those, especially with increasing numbers, they have a lot of confidence in what they can say. I don't think HD is there yet, from what I can tell. So another approach to dealing with this is to do a study where just a literature review. So you do this meta-analytic thing where you're looking at studies other people have completed, have your criteria, pull from that, and decide what's useful to report about. So this is the sort of thing that gets a lot, that can fund the ideas intellectually, ideas for more research about a condition. So a group of people, this is several years ago, it's a really nice systematic review. They started out with several hundred studies. They ended up with just 14 studies that met their criteria for looking at the aggression part of HD. And what was true of those studies they reported, aggression was not the primary focus of any of those reports. That's important to know. The diagnostic criteria for HD varied. Some were gene positive and very few. Most of them were just a clinical characterization of the condition. And they each used some different idea about what aggression was. And this is back to what I said before. If you don't have an operational definition that is across all those studies, it's harder to make sense out of them. So that's a limitation. So I thought about making this quiz, but I didn't. But here's what was reported from those 14 studies. Somewhere between 22.6% and 65.2% of the participants in those studies evidenced aggression at some point during their participation in the studies. The highest rate was one study that used a case records review that covered multiple years for each client, and sort of makes sense to me that the longer the period of observation, the more likely it is you're going to see something like that. And the lowest rate was with a registry that just reviewed utilization of scores for a behavioral subscale from the UHDRS, which is a standard, you're familiar with that, it's a standard score metric. So I don't think I want to spend a lot of time on this, but I thought it interesting that there were a number of different scales. Ideally, and I mean, if you have unlimited funds for research, you can just take all the good scales there are and give every single scale to everybody in your study and see which one falls out as being the most useful. That's not usually the case, and so you have to be thoughtful about what measure. But here's one, UHDRS does a good job of looking at severity and frequency of events for threatening behavior, physical violence, verbal outbursts, and threatening, foul, or abusive language. So it does cover the critical issues with aggression. The problem behaviors assessment for Huntington's disease, this is a British scale. You can tell it's a British scale because it had U in it. I was wondering, as I was putting the slides show together, I was trying to figure out, and there are a couple of scales that I use in my clinic for behavior that have a U in them. They're all British. And so I asked Siri this morning, why do the Brits still use the U in there and we don't? And all Siri would ever say was, there is a problem here, which meant she did not know. And it turns out that this is, by the way, an aside and not really part of the topic, just in case you're curious, when the Americans re-standardized dictionaries several hundred years ago, we did the dastardly thing of dropping the U. The American Canadians did the same thing, because why do you need an extra letter when you don't need one? And the Brits have never forgiven us for that. So anytime you see most scales that have a U in them, it's probably a British scale. So this is a semi-structured behavioral interview, and it looks at the ratings for frequency and severity for certain problem behaviors, and it gets information from patients, which was one of the first. Instead of just observational information from patients, they got self-report from patients and also from caregivers. And RAGE is another one that looks at issues over a several-day period, looking at overt behavior, consequences, and then offered a global judgment of aggressiveness. Yeah. And then several others. So in case you ever see these, Udovsky aggression scale, the present state examination. So there are a number of scales that have been used. Not one has been selected as superior to the other. So here is quiz item number 2. You guys did really well, and so there are probably no prizes for this. If everybody wins, it'll. But what's your guess as to the prevalence? Is there a difference between the sexes for prevalence of aggression? Yes, and so there is, and so what would that be? Okay. I would have said the same thing. So for these studies, there 3 studies showed similar incidence of rates across males and females, and several studies showed a higher incidence in males. Now, what was not reported was, and I would have to go back and go to the original articles to see how many people were in each of those studies to make more sense out of that. I would have guessed the same thing as well. One study showed more likely to have aggression early versus latter stages of the disease. I would have thought just across the spectrum myself. And then one showed that verbal aggression was more prevalent in clients with 8 to 9 years of duration of illness, with a similar increase in physical aggression at that stage. So what does this mean? The incidence rates are all over the map, which is, again, small samples. That's kind of what you'd expect. So here's your 3rd quiz item. Is there a relationship between cognition and aggression? And so what's your guess as to what that is? The smarter you are, the more aggressive you're going to be. It's not a smart thing, by the way. That's not the right word to use. The more cognitively impaired you are, you might be more aggressive. So again, small samples. One study showed no correlation between MMSE and aggression. Are you familiar? Do you know what the MMSE is? All right, so no study. And one showed a weak correlation between aggression and functional rating scales. The more functionally impaired somebody was, not necessarily a cognitive indicator, but there was more likely to be some aggression. And all right, let's, while we're doing the quiz thing, what about physical variables? Do you suppose there are any physical variables associated with aggression? Care to hazard a guess? Okay. This gentleman is in the lead at the moment. There are higher incidence of frequency and severity of aggression in participants with higher rate of falls, which would be an index of greater physical difficulty. And finally, and I think this is the last quiz item, although I could quickly come up with some more in case of a tie, are there any psychiatric correlates that you would expect? I mean, you'd sort of think common sense-wise there should be. And so here's what those studies, again, small sample, showed. One study showed participants with OCD symptoms had a higher aggression score. 2 studies showed that the rates of aggression were correlated with suicidal ideation. So some negative neuropsychiatric symptoms, this is, my wife sometimes says, well, I read that study that you told me to read, and I can't believe somebody actually funded that. to tell you what you probably already knew. So people with more neuropsychiatric conditions may be more aggressive. Shock of shocks. All right, in terms of treatment, so there were 14 studies that made the cut for looking at aggression. There were 19 studies that made the cut for looking at components of treatment. And again, small sample sizes, primarily medication trials with 2 studies that with non-medication. One of those included medication and non-medication. It was a mix of female and male participants. The age range was broad, 16 to 74, most in the 30 to 50 range. The duration of HD was not always reported, and this to me was just an interesting side bit. The MMSE ranged from 0 over 30 to 30 over 30. Now, if you're familiar with this, this is it's a simple. I've got some patients, by the way, who download. It's in public domain, so you can get it. So I've got some patients who come in for mild cognitive impairment or dementia exams who will look at this the night before and study it. So I don't use this one anymore. I use another one that is similar, but I have never had anybody get a 0. 0 is you cannot answer correctly to anything. Your age, your date of birth, where you are, there's nothing. And so I'm assuming, without looking at that original article, that's probably somebody who's just totally non-responsive. And so maybe they are that cognitively impaired, but maybe they're just nonverbal. So that's maybe a little bit of an outlier. All right, so these are the treatment studies. One, in terms of measures of outcome, one study used a recognized behavior scale. I think I mentioned this one briefly. We flew through those, the Cohen-Mansfield Aggression Inventory. And most simply relied on author descriptions of the physical, verbal activities against objects and furniture and people and so forth. One study referenced pre and post CMA scores, the Cohen, and there was very little in terms of true evaluation pre and post and so forth. And there was a placebo control, for only one of those studies. So again, these are limited designs and small studies. And so here are the medicines, and I purposely did not list all the medications because, again, psychologist, not a psychiatrist or psychopharmacologist. I'm at a teaching university, so psychiatry residents routinely rotate through my clinic with me, and it's always been interesting to watch them in my interaction with patients. When patients always ask me about medicines. I know some of them are really nice. I know you're not a real doctor, or I know you're just a psychologist. As my wife was explaining to my 4-year-old granddaughter the other day what I did, and she said, well, why didn't he just become a normal doctor? That's a really good question. So patients ask me about medications, and so I will say, I'm happy to give you advice about your medicine. And the psychiatry residents' eyebrows go way up because they're thinking they're about to hear malpractice. And I'll say, my best advice to you is talk to the prescribing doctor about those medicines, because nobody else knows your condition better than you. They've taken a careful history. They know everything about your biology, or they should, and they know how you reacted to stuff and so forth. And then the psychiatry resident calms down, and we go on about our business. But so the antipsychotics have been tried alone, in combination with SSRIs or beta blockers. SSRIs have been tried alone or in combination. Beta blockers have been tried. And again, small samples, but what is the outcome from those different studies showed varying degrees of efficacy. And there is no, as I understand it, Dr. Wong, correct me if I'm wrong, but there's no clear consensus at this point as to medications that are going to be the most efficacious for this condition, which means more careful, thoughtful research needs to be done. There were 2 non-medication interventions. One was what was referred to as the Sentry modulation intervention. So they carefully took the time to identify triggers for aggressive behaviors. This, to me, and I'm biased as a psychologist and biased as a psychologist who in graduate school, if you'd asked me what my theoretical perspective was, I would have proudly said I'm a radical behavioral perspective, not a cognitive behavioral perspective, but a radical. I've mellowed over time, or have, as a behaviorist, I should say, I've been shaped into a more moderate approach. Anyway, taking the time to look at setting events to me is really critical. I think very important. And they also looked at sensory profiles. They looked at things that were sensory preferences for certain people, what calmed them, what they enjoyed, what they gravitated toward, and also what they were averse to. And we all have our own kind of, I mean, you can take this out of the clinical population. We all have certain sensory preferences. There are certain noises, sounds, touches, tastes, smells that we gravitate toward, and some that we really don't like, and so forth. And so they took the time to plot that out as best they could. And their treatment was a sensory modulation treatment, as the title suggested. They used early on in the escalation of behavior, not when it reached its peak, but early on, they would distract the individual with a weighted blanket, a puff massager, and I still can't find I've looked for exactly what that is. I know what click-clack balls are, and I don't understand why that is calming to anybody. That is just what they say they are. Those acrylic balls or some other that are on a string, and you hit them together and they clack, click and clack, and they make the most god-awful, obnoxious noise. And so if I were in the height of an anxious reaction or an aggressive reaction, somebody came at me with brightly colored balls that were clicking and clacking, I just don't see that as the method of intervention for me. But that's just me. But what they found was if we intervene early in the escalation, and these are people who took a lot of time to think about what's the setting in which this is more likely to occur. We're going to watch for a little bit of an escalation of aggression. We're going to intervene very quickly. We're going to use a weighted blanket because we know they like that, a massager, click-clack balls, anything to distract them from this. And what they found was a nice decrease in the incidence of aggression. And the second one was a behavior support plan. So this was a medication plus, right? So they implemented a new medication regimen, and then in several weeks they started the behavioral support plan. And in the behavior support plan, there was a systematic monitoring period. So they, again, took careful time to find the antecedents to the setting events that were likely to be there in the context of the aggressive behavior. And they introduced this behavior plan, a very highly structured daily routine. They did what they could to minimize some of those triggers that they had identified. And they spent a lot of time rewarding what they called desired behaviors. Right? So behaviorists call this, they call it different things, but differential reinforcement of other behavior. So if you think about it like this, whether it's somebody with HD or whether it's your kids not playing well with others, if tantrum is one behavior you don't want to see and cooperative play is another behavior, you can't really do both of those at the same time. It's really difficult to do that. I have seen it done, though. My grandchild, who could not be here today to demonstrate, we have her on a schedule. This is not my schedule, but she now has, when she comes over to our house, because she wasn't watched closely, I'm going to blame my wife. She's not here to say it was her, not me. She got on the iPad. She got on YouTube for Kids. She found some goofy family who does this goofy stuff. And so now when she has to be pulled away kicking and screaming from the iPad, she does her tantrum. So she did her tantrum the other day, and my wife said, if you stop crying, I'll take you to Belk to shop. And it was the most amazing transition for a 4-year-old. She stopped crying, she looked at me, and she sort of stood up a little bit taller and did a little thing that was flirting with me, I think, if that's flirting behavior. Will you buy me something? And so you can almost do both. But in this case, they rewarded cooperative play in those settings that were the aggressive behavior was likely to occur, and they used a lot of tangible rewards in addition to praise and so forth. And what they found was, over the course of time, they had a dramatic improvement in behavior within 5 days, which is really phenomenal. And they reported that when these were individuals who were in a special care center going back to their nursing homes, they were able to transfer that training back to the nursing home, which is astounding. If you've ever, some of the nursing homes I've been in consulting in the past, where I have said, I think I know what's going on here, and all I need for you guys to do is this. That's the last thing they're going to do. So to get the cooperation of a setting like that to do that, to me, is just astounding. But they said they had a really nice transfer there. So what's the take-home message from all of this? wide variety of medications have been reported to treat aggressive behavior, but small sample sizes, poor measurement and evaluation of the treatment efficacy, and no randomized clinical trials or other methods to clearly identify the critical agent. So there's not a clear consensus, there's not a standard of care at this point, but at least this is a starting point for decision-making at the clinical level for decisions about medication, non-medication treatments. If you are, say, approaching your physician for your loved one or for yourself, you can say, you know, and how you say it, by the way, we'll come back to that in a bit. If you go in and say, I read a really interesting report that says if you'll put me on this antipsychotic and this beta blocker, that I should be better with this aggression in a couple of days, I'm just going to guess you're not going to get the outcome that you expected. So how you talk to them is really important, and I'll explain why I think that is. But this is at least the foundation for future research in terms of more careful thoughts about what goes on in settings that will make it more likely that aggression is going to occur. What are the factors behind that so you can think about intervention? Now, since I got to make up the talk, I wanted to talk a good bit about the behavior analytic perspective on this because this is my bias as a psychologist. When you're an undergraduate in psychology, was anybody here an undergraduate in psychology? I am the only one. Thank you. We'll talk later. You get exposed to all kind of the number of models that we as people have come up with to try to explain why we as people do the stuff we do is absolutely astounding. There are so many different analytic, psychoanalytic, behavioral, cognitive behavioral, and I'm not doing them justice because there are hundreds of them. There are whole books on theories of personality and so forth that are about explaining those behaviors. One of the most elegant, in my opinion, is a behavioral approach that looks at three things primarily. It looks at the behavior itself and looks at careful descriptions, those operational definitions of behavior. In some of the original research, actually there's research that goes back before this. B.F. Skinner was a psychologist who ended up at Harvard but was somewhere else before that. And one of the research designs before that was a T-maze where you teach a rat something and there was a reward at one end of one side of the T-maze and so forth. And you were looking at learning among other things. And so what he thought was we could probably do a little bit better. We need to measure behavior, but this may not be the way to do it. So he was interested in one thing at that point, which was rate of behavior. Let's just study rate of behavior. If we can see it increasing and decreasing, we can begin to understand factors that may be affecting that. And so this whole idea of contingencies of reinforcement is simply that if you are careful about looking through and thinking about the events, the environment, the things that set the occasion for the behavior, and you're careful in thinking about the consequences for that behavior, then you can begin to you begin to appreciate what factors might be contributing to the behavior, then you're also a step ahead toward trying to manage those behaviors. And so a couple of silly examples. Aggressive behavior, as we've been talking about, if the aggressive behavior is in the context of a group home, well, this is a bad thing, right? If that aggressive behavior is in the context of an MMA class, mixed martial arts, then you're going to get not only not punished for that, but get rewarded, and you'll be the cool kid in the class if you can dislocate somebody's shoulder quicker than somebody else. So it's all about that. And yelling in a group home, not so good. Yelling at a basketball game, perfectly okay. Yelling at a Protestant church, probably not so good. Yelling at an evangelical church, probably okay. So setting event is really important. So let's look at what the literature says about setting events or motivational operations, if you will, for aggression. One of the more common is pain motivated. That is, people who are in pain or discomfort. This is, you can say, well, that's really more of an internal variable, but it is. I mean, it's a motivational operation that sets the occasion for aggression. When you are threatened to the point that your life is threatened, or you feel that your life is threatened, which is probably more important, aggressive behavior is not uncommon. One of my undergraduate professors, in discussing stuff like this, he always used the cavemen story, as in back when we were all cavemen and people were fighting for food and you had your chunk of meat because you killed that pterodactyl. And so you had this meat, and somebody else slapped you and then tried to grab the meat. You got angry because you got slapped. You got angry because your food was going away. And if you sat down and said, let's talk this through, you were probably not going to be eating that day. But if you aggressed against them, that was probably going to be heavily rewarded. And so he says that's why we are all aggressive now, because that trait got passed along. So as in the people who were more aggressive likely survived early on and passed those traits, a Darwin sort of thought. And I asked, how good is pterodactyl anyway? But that's beside the point. But it is true that pain is a very prime situational setting event for aggression. But it's not the only one. And here's what happens. This is the consequence, that you are reinforced for that behavior. So when you aggress against somebody, this is being reinforced, which is what increases the chance that that happens in those settings in the future. But there are some others. Extinction-motivated events are precursors for aggression. I can replicate that anytime I want with my 4-year-old granddaughter with the iPad. Whenever we take her away from the iPad, put her on extinction for that pleasurable activity, she will throw a tantrum until you bribe her with shopping or something else. But also interruption of stereotypic behavior. So I was watching this really interesting movie the other night with Ben Affleck was in this movie called The Accountant, and he apparently is this high-functioning autism spectrum. And so in the movie early on, he's putting puzzles together upside down so you can't even see the puzzle item, and whenever he got interrupted, when they couldn't find the last puzzle piece and so forth, he got very upset because it stopped him from, it was part of his stereotypic routine. And so this is not an uncommon precursor for aggressive behavior to interrupt that sort of thing, and all those get heavily rewarded. Now, you want to think about this as bidirectional, and that is, it's not just, you don't think about contingencies of reinforcement just with the individual who's being aggressive. If you are interacting with them as caregiver, loved one, whatever, your behavior has an impact on them and their behavior has an impact on you. So if you think about this, so let's take an HD individual who has an extinction-motivated event. You're managing a group home setting, the TV's on, it's time to go do something else. TV is highly preferred activity for this individual. You turn off the TV. They get angry and come after you verbally or physically because you took away their TV. Then your behavior at that point is going to be really important for a number of things. One is going to be what's it going to do to really handle the aggression, and then how does your behavior affect them? So if you aggress back, if you simply raise your voice and are very abrupt with them, then that might control their behavior depending upon your historical relationship with them. Sometimes raising your voice, works. It's why most parents do that, because if you're a parent, you run out of your repertoire of behavioral skills very early on in the cycle. If you had a child who's colicky, you know what I mean. When I was in graduate school and about to have our first child, a friend of mine who I thought was as near sainthood as you're going to get, who had 2 children, said, I want to tell you this so that when it happens, you won't think that you need to go check in somewhere. Your child's going to keep you up late. You're worried about, you're working on stuff. You're going to be exhausted. You can't get control of her behavior. And you're going to have this brief, fleeting thought of anger. And then you're going to have all this remorse because of that brief, fleeting thought about this infant in front of you. When it happens, don't worry about it. Take a break. Get your wife to take over. Go do something, and then go revisit it. And we all it's when we run out of our repertoire for managing something, anger, fear, being upset is a very common response. Let me see. Let me think about. No. The problem is, so it may work. So if you raise your voice to this person, it may get their behavior under control, but what might happen later if you do that? Yeah. So I should have put that in as a quiz, because Sue Ann is now close to, you guys are tied. These things happen over and over again, right? So it's not just a one-time sort of thing. So if the HD patient aggresses towards you and your quick solution is to just get angry with them, don't beat yourself up, because in a pinch that might have worked, but then that shouldn't be your go-to, let's do that every time. Because one of the things that happens with repetitive punishments and repetitive rewards is the concept of satiation. Are you familiar with that? All right, so a reinforcer loses its value as a function of the number of times it's provided. So you can produce that with a rat who is, so by the way, if you did rat research, you keep the rats partially starved to do research with them, because a really well-fed rat could care less about whatever operant schedule you've set up in your operant box, because they're full. Okay, that's over there. I'll get to it when I need it. I'm not hungry right now. So, and you can see in a rat, if you look at frequency or rate of behavior, once they reach satiation, the rate of responding goes down. It doesn't stop, it just goes down, so there are longer delays between bar presses for this one particular thought. But you can replicate this in humans. So think about your favorite, absolute, without a doubt, favorite dessert. Get that in mind for a second. I'll share one of my favorite desserts. Unfortunately, I have a long list of favorite desserts. One of them is chocolate pudding, right? Now, not instant chocolate pudding. That doesn't have the right texture. But it's certain, that homemade that you have to stand over and stir, and you got to be careful to not overcook it or undercook it, because the texture is not right. And so my wife makes sure that I'm on a very lean schedule of reinforcement for that by never, ever serving that, ever. I've even tried to bribe my kids first and grandkids, go tell Tony that you'd really like some chocolate pudding, and it's never worked. But even if I were to get one of those big vats from Sam's of chocolate pudding, and I have no idea if they're any good, I'd rather not know. If I had continuous access to chocolate pudding, I would have, my rate of eating bowls of chocolate pudding would be pretty high for a while, but hopefully it would begin to drop down. I would satiate on that. It wouldn't be that I lost my taste for it. I still like it, but I'll get back to that later. Same thing happens with any reinforcer you use for management of behavior. If you use it too frequently, over time, it's just going to happen. And the same thing happens in a different way with punishment. If you punish a behavior as the main way to control that behavior, sooner or later that punishment is going to be a little bit less effective, so then you got to punish again, or punish at a more noxious sort of stimuli. Years and years ago when I was in graduate school, I was part of my one practicum was at a facility for individuals who are severely intellectually deficient, kids through adults. And most of them were very pleasant. It was just a long-term residential facility. But there were some in each cottage who were mildly to moderately to severely aggressive, and the severely aggressive ones were kept somewhere else, mainly for the protection of the other residents. And when I first got there as a trainee, one of the techniques, they gave me an apron with slots in it for Fruit Loops. I thought, well, this is a great place to work. They give you, but these were for the patients. They were not the residents. They were not for me. And these were rewards for certain behavioral schedules they had set up. And they are also, I told them, but for me to be a really good behavioral technician, I need to be rewarded every once in a while for the behavior of doing this, so I'm going to reward myself contingent on that. So they were okay with that. But they also talked about ways to punish certain behavior that was used in isolation only when the behavior was really so bad that you really had to get it under control. So they actually had, they had a cattle prod. Now this is late 70s, so this is a really long time ago. And so I said, well, okay, tell me how we're going to use this, and I want to try it on myself at the lowest setting. And I tried it on myself at the lowest setting and never used it, because it was, even at the lowest setting, it made an impression. A significant impression, not a scar impression, but an emotional scar. Well, really not. But what we did use is water bottles that had a spigot on them that you could control from spray to a shot of water, and would keep those in the freezer. Now this, to some people, this sounds absolutely horrible, but let me explain the use. So there were a couple of kids who did a lot of self-stimulation, and some of their self-stimulation when they were more agitated was just a horrible thing to watch, because they were literally slamming the palms of their hands into their teeth. They were losing teeth. They were getting scars and infections and so forth. So this was a disastrous thing happening. And so you look for different ways to get that under control. And one of the things that did work is if you caught them early in this self-stimulation aggression cycle, one quick shot of cold water to the forehead, not in the eyes, and it would stop. And then, so over the course of one weekend, we had one young lady who went from an uncountable number per hour to none over hours, and then we could begin working on other behaviors that were counter to that. And then, of course, weekend would pass, and then the house parent would come back, and whenever they would get upset and start doing this, they would show them a lot of love and affection for their aggressive behavior, and the aggressive behavior would go back up. So we would learn to get that under control. But you can use punishment to quickly stop a behavior, but that shouldn't be your long-term go-to solution, because it will be problematic. So you can think about, and I'm going to stop in just a second to think about questions if there are any. In terms of behavior management, you can control, we all want to control the behavior, and there are times when you can, when your kids are really little, you can stop a tantrum just by picking them up and holding them in a loving fashion, by the way. Also in the Ben Affleck movie, that when he was younger, that's what his dad, I'm not sure Dad was thinking about this as a behavioral process, but when he would throw his tantrum, he would just wrap him up firmly but not aggressively and hold him and calm him until everything stopped. And then he had other really unusual methods of treating him, but you often don't have that. Especially as your kids get older or you're dealing with adults and so forth, you can't just directly stop a behavior. You have to think about, what are the setting events that I can, based on my observation of what seems to be important, and what are the consequences I can think about that might be useful? So this is certainly not an exhaustive list, but these are the sorts of things to think about. But what this really should come from with individuals you're dealing with is you have to spend a lot of time watching them over time in a systematic way to figure out what are the motivating operations. But noise sensitivity, not an uncommon one. So that seems to be, so that's a simple one. So I can manage the volume. So let's say it's a group home and one person really likes the volume on very high and this really aggravates the other one. You've got to modulate the volume for this person, or get this person a set of noise canceling headphones, convince them they're really cool, and and then reward him wearing those enough so they get used. So it's a multi-intervention sort of thing. Extended hunger and thirst are also not an uncommon trigger for anger. So thinking about readily available snacks and fluids and so forth. And if you're thinking, because you're trying to think about competing behavior, I'm jumping ahead to reward stuff, but you can use those readily available snacks and fluids during the day as rewards for behavior that is incompatible with the aggressive behavior. So you're killing two birds with one stone, if you will. Physical proximity to other people. So this to me was one of the most, I had to learn tact when I was at the residential facility, because some of the people who worked there, who were the ones who were most likely to get hit, were the ones who were just out of the kindness of their heart. When somebody got very angry, they got very close to them to try to comfort them. And so you'd say, the wrong time to be right in their face is when they're really angry. Well, I'm just trying to help them. I understand that. But so it's getting very close to somebody who's very angry is really not a good idea. And if you're thinking about another kind of residential setting, too many people, thinking about capacity management, if that's at all possible. Fatigue, also not an uncommon internal variable. So sleep schedules, planned rest periods, and environmental extremes. So heat especially, but also cold. Extremes in temperature and other environmental conditions may not matter to some people, but they may be triggering events for others. So those are the types of things to be thinking about. But really, it's very important to just be watching. You want observational periods over time so you begin to get a better appreciation for what might be the triggering events. And then a very short list of consequences. Timeout has been, anybody here in favor of timeout or dead set against it? Timeout empirically works. Timeout, and all timeout means is timeout from that available reinforcer. And so, but nobody ever says that part. And so I can remember a client I had when I was in practice in Hattiesburg in Mississippi, where they were using their behavior plan to get this, an otherwise pretty nice kid to quit being oppositional. They would put him in timeout for periods of time for being rude to his mother or something. And so I would say, well, how long is he in timeout for? So, well, they said the first time he does it is 10 minutes. Okay, all right. And then the next time it's 8 hours. So, okay, that's not good. This was really an isolation room. So it wasn't just go to your room. when you're my generation, my parents, if they ever sent me to my room, that's where I had all my stuff. So, okay, I'll go to my room. But this was an isolation sort of thing. So timeout for very brief periods of time, just to stop the cycle and get them back in for more learning is useful, but timeout for extended periods of time has really limited benefit. We've already talked about this some, the idea of reinforcing competing events. So this takes some thought to what the behavior is you're trying to get under control, and what is a behavior, hopefully, that's somewhere in their repertoire already that you could shape up that literally can't coexist with that behavior. And then you can think about response cost procedures. This is an escalating sort of thing where they're losing highly preferred items. That would be a crank call. Contingent on crank calls have gotten really more sophisticated now. They're getting anyway, that's a little bit of an aside. And it's not the air conditioner people, so I won't answer that. So when you think about response cost procedures as that are escalating consequences for loss of certain things, but you also have to think about getting those things back in their availability, because if you, again, families I've worked with over time, they will take away stuff for semesters at a time. And as I, and then I'll say, well, what is the motivation for this child to do whatever you want them to do? Because you've taken away everything that they hold dear until, January. So what's in it for them? Well, they should just want to do this. And so that's when we have a discussion about, contingencies, reinforcement, and so forth. All right, so I think now we have time for questions. Yes?
Occasionally gets very he's non-communicative verbally, but he gets very vocal with yelling. And since we can't talk to him and ask him, if there's something frustrating in which I'm sure there is constantly, a lot of times we don't know why he's yelling. And then if I'm not there, their answer is to just give him more medication, basically. So is there any suggestions that you have for people that you can't ask what's bothering you?
Sure, and it's
I can try to figure it out, but I usually won't.
Either, so somebody is probably going to have to. Oh, that's right. That was one of the rules you gave me before, and I'm not going to get a star for this. The question is, what do you do? I'm going to paraphrase. He's in a residential facility. He's nonverbal. And so how do you figure out for a nonverbal individual not living with you what's going on to get him upset? So it's a great question. This is what we've talked about already. It's the behavioral observation. Somebody is going to have to spend the time to observe enough to get a feel for what the things are that may be setting the occasion for that. If it should be somebody at some staff at the residential facility. Ideally, they have somebody tasked with and or trained to do that. If not, then it could be you. The problem sometimes, not always, but sometimes with a family member doing it, the fact that if his behavior gets better when you're there, then your being there it's like, okay, all I have to do is be here all the time and he doesn't aggress. We have solved that problem. Somebody else who he doesn't know might need to be the observer. So maybe getting an outside person to be the observer, somebody trained in behavior analytic kind of stuff or observational stuff who could then appreciate, and probably, this is my guess, I could be totally wrong, probably not going to be that lengthy of a process. They may identify some things relatively quickly, and then there are certain ways, if you're doing this correctly, to test those out and see if it's really this one or that one and so forth. But that would be the route to take. Certainly. All right, so here's a question from somebody online. How do you handle aggression in the HD patient who does not recognize their aggression or who feel justified because they have fixed delusions of being wronged by another? I think some of the things that I've already discussed still apply here. You notice I didn't mention in the behavior management of this anything about insight, which is really good because this applies to me too. I don't have to have a lot of insight into my behavior to make some changes in it. which is a gratifying thing for my wife to you just need to be different. Don't worry about why you're being different. But all kidding aside, this is back to simply my approach would be not so much, I mean, if you want to get them to be more appreciative of what's going on with them, that's another thing to be training somehow, is their awareness of their behavior. And you can think about, you need somebody who's good at doing this sort of stuff, because this is, I really think some of this takes some professional psychologists, people who are trained in applied behavior analytic. In some states, like in Mississippi now, the laws have been passed, so there are some board-certified behavior analytic people who are bachelor's level and master's level, so different levels of sophistication. But somebody who is going to be systematic and careful enough to watch that, to get the aggression under control. And then if you want to try to train them to increase their awareness, but then the delusional thing is it's a whole nother problematic, because that sounds like a rabbit hole, because you're not going to get them to, I have one friend I was in training with in Houston who was really fascinated by schizophrenics, and he thought if he sat with them long enough and got into their delusions with them, that he was going to get them out of those. And he's now working with homeless people in Los Angeles, and he has yet to get any of them out of that delusional state. That's just not going to happen. That process doesn't work that way. Question online, can you send us some more details about that systematic review? Let me think. You could go to ABAI International, Association for Behavior Analysis International, probably a good start. It is more, I think, and if somebody here knows more about the site, I hadn't looked at it in a while, that is more for practitioners and professionals, but it may have some resources for individuals who just want to find out more about it. And this is an interesting, behavior analytic theory when I was in graduate school back, years and years ago, was something where it was really interesting as a theory, but there wasn't a lot of applied work going on. And now it's everywhere. There are centers, for-profit centers, not-for-profit centers, everywhere. I say everywhere. According to the ABA podcast, they're everywhere. And that's another one. You can find a lot of really good podcasts for applied behavior analytic stuff. If somebody were to email me, I can send you some references for some things to look at. That would certainly be fine. Other questions? Yes?
So to kind of summarize,
I like chocolate pudding. Sorry.
But providing like incentives and sometimes punishments, but basically redirection rather than trying to explain to the person or trying to basically talk them out of what's going on isn't going to get you very far.
And sometimes, yes, sometimes talking them out of stuff. Funny you should mention that. I have to give when I see my grandchild tomorrow or the next day, I'll give her credit, because my wife was telling me just this morning I had to talk with Sudi about honey versus vinegar. You can get more flies with honey than with vinegar. And that was completely over the head of a 4-year-old, because she was also not interested in hearing that talk. But for the most, there are some times when, yes, insight might be helpful. I'm not really that negative about that. But mostly it's thinking about, in what settings is this likely to occur? How can I manage settings to minimize the risk that this is going to happen in the first place? And then how can I modify consequences that I have some control over, positive or negative, hopefully positive more than negative, to try to train this so this is less likely to occur. Maybe I'm going to shape up something so something else occurs so it can't occur simultaneously, or I'm just going to get rid of this somehow. That's the approach I think is most efficacious. Was there one more? I think. Oh, here. How do you de-escalate aggressive behavior? Okay. When you're in the middle, what is that? I'm trying to remember. One restaurant I used to work in when I was in graduate school, there was this poster up on the wall that said, when you're in the middle, when you're up to hearing alligators, that's not the time to think about draining the swamp, or it was a little more graphic than that. But if you're in the middle of heightened aggressive behavior, that is not the time to think, let me rethink my approach to this. You have to get through that crisis, and then you have to back up and be thinking about this. And so, again, now there are some, in my personal experience, some people who are aggressive, it is literally 1 second they are happy and the next second they're blowing up. More often than not, if you watch, you can see this kind of things leading up. So you want to this is what, it's all about really good observation so you can catch things very early on, always very early to intervene early as opposed to later. And so I think that's a very simplistic answer for that, but I think that would be the approach. And another question on here, I find timeout for me, remove myself from situation to physically different part of the home more effective than timeout for my partner, then regroup later or next day. So that's not really, I mean, technically that's not timeout, although if you are a highly reinforcing event for your partner, then you're putting your partner on timeout from you by being in another room, but you're also giving yourself a break so you can regroup, which so makes perfect sense to me. Yes?
Sometimes I find it more personal as well as ADHD looks at their deviated and it's nonverbal, but sometimes when I talk with the doctor, that's with some of our amazing behavior nurses, right? That sometimes Paul's just trying to get his words out, you know, he's just trying to tell us something. So he might, his arm might go like this, he's not intentionally hitting you because he can't control that movement, or he is maybe trying to grab you or hug you or help or grab for the apple juice or something. So there is a lot of connection that a caregiver in the facility needs to try to make with their loved ones with HD. So they just don't give them another pill, right? Another calm down, but you know, a lot of times Paul's just trying to get his words out.
So if I can paraphrase for you, because that didn't hit the microphone, sometimes behavior, especially if you are in close proximity to that individual, might be perceived as aggressive behavior when it's not aggressive behavior at all. And so treating behavior that's not even aggressive behavior is really just, it's not effective. And so the people around the individual have to be very careful to watch enough to appreciate, oh, you know what, whenever he's frustrated and is trying to communicate, don't get right in his face because he's going to move around. And if you're in his vicinity, you're going to get hit, but it's not a hit. You're in his way while he's trying to express himself. So maybe don't be in his way.
And then sometimes nurses, my favorite nurses, but they'll say, hold on, that today. And I think, well, what's making that? Well, keep flung towards the tray. And I'm like, well, maybe he was hungry. Then maybe he wanted apple juice. Well, he threw himself there. And I'm like, okay, first of all, he's not throwing himself because I don't think he physically can throw himself. He's trying to get there.
His motor skills are such that if he's trying to get whatever, he may, I mean, look to you, that's what happens, right?
Well, he can't sit down, but he doesn't walk either, but everything is so much more rigid than you and I who are healthy.
So educating the staff about typical manifestations of a condition so they appreciate what is really aggression versus just part of the manifestation of the condition, very important.
And that has to go on over and over because the staff change and turnover, so it's something that as a caregiver, you have to be prepared to just kind of constantly inform the staff of the symptoms and what's going on with that person.
Yeah, so if you're lucky enough to work in an institution where you get the staff to buy into whatever model that seems to be working, it is, as you said, it's a repetitive educational thing. And you can't think, well, okay, for the month of April, I'm going to deal with staff training for behavior management. Then we're done with that and I can move on to something else. You're always going to have to cycle back through that because even people with best intentions, there will be a behavioral drift where they will kind of, their consequating behavior becomes a little bit less precise. Their observational stuff becomes a little bit less precise. They start jumping to a lot of conclusions to kind of speed things up. And so everybody needs a refresher course on stuff.
And too, I mean, the problem too is that a lot of people that are working in the facilities have never even been around ever. They
No
have
clue.
no idea what it
How
is.
many?
You know, I mean, they know movement disorder, but it's different. I mean, we've got all these
So,
There's no training for them.
That's something I think HDSA has, very emphasized for the center of excellence to go to the facility
Yes.
in service. I think, if you have a loved one in a facility, invite your doctor or the team to say, hey, can you guys go there, talk to them a little bit, so that's very helpful.
Yeah, I mean, we've gone through it with several family members, and it's, extremely difficult.
yeah, and this is not an issue just for HD. This is for any residential facility where they have patients who are not their typical patient, who have different behavioral, motor, cognitive manifestations that they aren't aware of. Some of the staff are going to take some of that stuff personally, and then it all goes south pretty quickly. So it's a matter of educating them. And I've been a paid consultant. Places have paid me to come in and consult, and then they say, well, we don't really want you spending that much time doing this stuff. Well, okay. So there's effective and then there's not effective. And so this is going to be not effective, but, it's your nickel or whatever. So, but you got to get buy-in from institution. You got to get buy-in from the staff, because sometimes the institution is all for it and staff says, we're too busy. I'm off my shift. I got to go home. I got stuff to do. And I appreciate that. People have lives. And so there are a lot of moving variables there that have to be taken into account.
It just kind of seems like, I mean, I've worked in the hospital, and there are certain things that we have to do that are mandatory yearly. And to me, that is something that should be mandatory yearly, is to do a class.
Mandatory training of one sort or another. Yeah, I agree.
One thing that I recently became aware of is, and I think it's HDSA, is the toolkit for the caregiver and a toolkit for law enforcement. And it has a great, poster, it's a great toolkit that does educate, and it's almost like a go-to, it has everything listed of, this is how I'm going to behave, and this is how I need you to respond.
Okay.
And so it would be great to have that for nursing care facilities and residential facilities.
So to be sure to look to the HDA website for the toolkit as one resource for addressing some of those behaviors.
Yeah.
Yes.
Another thought would be, I'm a social worker for the Wisconsin chapter, HDSA, and part of my job is, facilities will contact me and say, we have a hunting exclusion, and we don't know what to do. So, I mean, your state or chapter has somebody like me who will be willing to go into facilities and do a youth service. I've had many staff members say, wow, we have no idea. This was so different from, other diseases,
So looking for local resources who would be willing to, even on a volunteer.
He also has a really nice book put together geared towards long-term care facilities. So I usually bring a stack of those.
Oh, okay. So another reminder to go to the HDSA website for the toolkit, well, not toolkit, but for the manual for residential facilities.
I know COVID has, taken a lot of the in-services out of a lot of facilities, and being able to actually go into the facilities, and especially like some of the nursing home and residential ones. But from an HD perspective, just being able to, like I said, some of them with Zoom, and I know we don't get the word Zoom, but being able to now get back into those facilities and re-educating, because it takes us to consistently continue to go, because the staff turnover is always an issue. So we're constantly, sometimes we feel like we're repeating ourselves, but we have to. And if we don't continue to, repeat ourselves, it's the only way that we can help make the change and continue to educate everyone on HD.
I agree. I agree completely, and just repeating the point that Sue Ann made earlier, that education is an ongoing, repetitive sort of thing, and very necessary, very critical. Oh. All right, so the antecedents seem to be different each time. I was going to leave before there were really any hard questions. The antecedents seem to be different each time. Is it best to just allow the verbal aggression to continue? Do HDs understand the caregiver's perception of the incident? Is it worth processing through, or would it cause more issues? I would say definitely no to the processing thing. And their insight, again, if you want to work on insight later after you got the aggression under control, great. You want to think about it, that's doable, complicated. If the antecedents seem to be different each time, this is back to the issue of systematic behavioral observation to see if, in fact, if there are multiple things that are going on that cause it to seem like it's different every time, to get a better appreciation for what's happening. And what literature would you recommend for helping an HD level 1 with aggression? I would think from what's been said from the audience, the HDSA website for some things. I think you can look for any, it's not going to be specific to HD, but the whole field of applied behavior analysis has information that could be applied. But that's a little bit of a stretch. That's like my guitar teacher telling me, go by that volume on all the scales that have ever been written and just work your way through that and come back and see me when you're done. You may need some expert guidance to take some shortcuts. So it's wonderful to read about stuff and the ABA things. And as I mentioned, some ABA podcasts. If somebody wants to email me, I'll try to send references that I think are useful. But finding a local somebody who is expert in some of these things for discussions with them and contact, I think that would be helpful as well. Yes?
I think just make a comment. So I'm one of the neurologists at Albany Medical Center, and so what I've found for our folks that are in clinic before they transition to a nursing home, it's really helpful in management of aggression. It's easier said than done. So I think a lot of times, people who are aggressively behaving don't know why they're aggressively behaving or believe the delusion, right? I believe in this thing that hasn't happened. Can't quite convince them that it hasn't happened. And I think oftentimes loved ones are stuck in, well, if you could just know that this didn't happen, then you'll stop doing it and everything's fine. And you end up just avoiding the way they handle the way they've come up with handling things is, I'm going to avoid it. So I'm thinking of a person who, he was compulsive about certain things. And so she systematically took away the things he was compulsive about so that he could avoid the task, and it just made him angrier and angrier. And so we couldn't just keep avoiding things. And part of what ended up being helpful for them was support groups for caregivers to remind them that this is just really frustrating, and we're going to figure out things that work over time, but that there's support for them too. And so not just what's your behavior, like all the stuff you talked about for sure, but then how else do we support, right? So in all the other ways. So just to remind that caregiver support groups are really important.
Sure. Multiple levels of treatment or management for caregivers and for HD individuals and so forth is really necessary, because this is a giant moving target for problem behavior.
Just not the folks that are aggressive, but like sort of everybody around them.
Sure, exactly.
So thank you, everyone. I do want to give a plug for the HDSA website while I'm up here. You'll find those toolkits that you referenced earlier under publications when you look on our website. If you are in search of a support group, please also utilize our website as well. We have virtual support groups running all the time, specifically for caregivers, and then you can also find ones within your local community. So all of that's accessible on the hdsa.org website. I hope you'll join us for the Volunteer Awards Luncheon at 12 o'clock in the ballroom we were in before. And thank you, Dr. Manning, for your presentation.